Hello, my name is Geoff Bellingan and I work in London at University College London Hospitals. I'm going to talk to you today on the acute respiratory distress syndrome, ARDS. Slide 2, please. In this talk, I will look at some of the more recent issues in the definition, understanding, and management options in ARDS. The main themes to be discussed are listed here on this slide. Slide 3, please. As many of you will know, the definition of ARDS is important. It is a syndrome and has many different causes, all leading to a relatively common clinical and pathophysiological picture of increased lung leak with edema and acute inflammation, which drives a refractory hypoxemia and increases in lung stiffness. It is quite common on the ICU, and despite real improvements in mortality, this is still high if severe. When I first started, the mortality in ARDS was 90%. Thank goodness now for many patients this is below 25%, but we still see mortality of 45% or more in the severe category. Slide 4, please. It is now well recognized that the worse the oxygenation, the worse the mortality. But it is also with worse oxygenation that the lung is stiffer. So there's a tendency to want to drive the mechanical ventilator harder. But the harder we drive the ventilator, the higher the risk of ventilator-induced lung injury is. So we need to use lower tidal volumes, lower plateau pressures. This can be helped by prone ventilation if the patient is severely unwell, may be helped by PEEP, possibly by optimization and recruitment maneuvers, and probably helped by ECMO and potentially in 1988 by Murray et al., focusing in particular on the gas exchange and the chest X-ray, and then refined in 1994 in the American European Consensus Conference definition. This secured the PF ratio description of acute lung injury, less than 300 millimeters of mercury, and ARDS, less than 200 millimeters of mercury. The Berlin definition in 2012 added useful refinements, especially the need for PEEP. But as we all know, there are many challenges with the definition of ARDS. Are there subtypes of ARDS? Does the site of injury, the type of injury, or other key factors, host factors or disease factors, impact on ARDS and the outcome? And do any of these impact on how we should manage and treat our patients with ARDS? Slide 6, please. Other people argue we should expand the definition. The Kigali modification is an approach by adapting the Berlin definition of ARDS for resource-poor countries, using saturations, not blood gases, and using chest X-ray or ultrasound. There remain questions if we can have ARDS using only high-flow nasal oxygenation rather than intubated patients. And what are the real PEEP requirements for ARDS? These are all fair challenges, but use of these would probably increase the number of patients with the ARDS diagnosis, but also will probably increase the number who recover within 24 hours, suggesting this is not really right. We'll look at this further in slide 7. Next slide, please. Here on slide 7, you can see that we know ARDS is not a quickly resolving condition. This is something that typically takes weeks, in some cases even longer, and it's one of the reasons why we added PEEP in the Berlin definition, and that was because 10% of cases in the prior ARDSNet trials had dramatically improved or even been extubated within 24 hours of entering the trial, suggesting the more simple atelectasis was in play for those patients, not lung leak, lung edema, lung inflammation, and lung fibrosis. Future work must look at the categorization of ARDS and any subgroups, and we'll look at some of the evidence for this over the next few slides. Slide 8, please. There's been some research into the question of whether there are subgroups in ARDS. This story is still evolving without enough definitive studies. So far, only about 25 papers with sufficient patient numbers have been published on this topic, and you will see the data is not yet conclusive, but there's definitively an evolving picture of at least a hyper and hyperinflammatory subgroup in ARDS. Let's have a look further. Slide 9, please. Caroline Calfee first defined the hyper and hyperinflammatory subgroups in ARDS, and that was published back in 2014. This is potentially important. ARDS is such a mixed bag. If we can break it up into more meaningful subgroups, it's possible we can find a treatment that works for one of these, and it's possible that our trials thus far failed because the subgroup that could benefit is mixed in with the other subgroups, and these swamp the results. Slide 10. Here we see Caroline Calfee's hyper and hyperinflammatory subgroups. The hyperinflammatory subgroup is less common than the hypoinflammatory subgroup. It has raised inflammation, raised IL-6, raised IL-8, etc., low bicarb. It has a higher mortality, a longer time ventilated than the hypoinflammatory subgroup. Slide 11, please. Her group has done more detailed work on this and suggests now that the 90-day mortality rate could indeed be different between these two different subgroups. And this is associated with a greater diffuse lung injury in lung morphology in the hyperinflammatory group, which also has more organ failures, and a deteriorating clinical picture over time, again in the hyperinflammatory subgroup. In slide 12, her group has started to analyze retrospectively other ARDSNet trials and see if they applied the hyper and hyperinflammatory subgroup to these trials, what would happen. So looking at the use of trials of statins in ARDS, in the HEART-2 trial, we see that in secondary analysis, the use of simvastatin would have benefited the hyperinflammatory subgroup. But in the SAILS trial, we see that the use of rosuvastatin did not corroborate this. And here, secondary analysis could show no benefit from statins in any subgroup. So from this approach, we cannot be sure that these two subgroups do help distinguish. However, there's more to the story. Slide 13, please. When we look at the responses to PEEP and subgroups, secondary analysis of the alveolar trial showed that the hyperinflammatory subgroups benefited from higher PEEP. And this was also shown in the LungSafe trial. So there may actually be a benefit of a relevance of these two subgroups. Looking further, slide 14, please. Secondary analysis of the FACT trial of fluid balance in ARDS has also suggested that the hyperinflammatory subgroup of ARDS benefited from a more liberal fluid management approach. And in slide 15, practising in Caroline's group was recently shown in further analysis of the ROSE trial that the hyper and hyperinflammatory groups have different clinical and gene transcription characteristics. He looked at 134 patients and measured the gene transcription and protein product on day 0 and 2 days after in ARDS, and showed that the hyperinflammatory group enriched for genes associated with innate immune response and tissue remodeling, and by day 2, enriched for collagen synthesis and neutrophil degranulation. This strongly suggests that there are at least 2 distinct subgroups within ARDS and could be a way forward for the future. Slide 16, please. We have a long way to go with the question of, are there different subgroups in ARDS? We don't know how good or how quick is any classification. We don't know whether these groups are stable over time. We don't know whether different countries and populations have similar subgroups, and really if these subgroups can influence outcomes to new treatments. But this is exciting, and really you must watch this space. Slide 17. On more practical matters, we can ask the question, can we avoid intubating patients with ARDS? We will all be aware of high-flow nasal oxygenation, and there are now several studies that show this can give a consistent FiO2 and may add some PEEP effect with higher flows. Overall, prior to intubation, we do not see any mortality difference using high-flow nasal oxygenation therapy compared to standard oxygen therapy. But it does seem that high-flow nasal oxygenation significantly reduces the need for intubation in ARDS. So this is quite exciting. In slide 18, we're looking at studies that have compared the use of high-flow nasal oxygenation with non-invasive ventilation. And this didn't show any difference either for mortality or for the prevention of intubation. But that suggests that high-flow nasal oxygenation, which is often easier to use and better tolerated, is just as acceptable as non-invasive ventilation. Although one study suggests the use of the non-invasive ventilation would significantly reduce mortality, but this is a result of a single small study of a single center, so open to significant question at this stage. Slide 19. What about the use of low tidal volume ventilation in ARDS? There have been a limited number of studies, and they all differed somewhat. 2 trials were stopped early for futility, but 3 were stopped early for benefit. And when they were pooled, there's a strong trend but non-significant benefit from low tidal volume ventilation. But the powerful impact of the 2006 ARDS trial has really stopped further trials in this, and low tidal volume ventilation should be well embedded in our practice now. Slide 20. Despite the statement from the previous slide, we see that many places are not really using low tidal volume ventilation in ARDS uniformly and consistently. This recent study across a number of Asian units showed that only 65% of patients with ARDS were on less than 8 mils per kilo tidal volume, and under 3/4 only had sufficient PEEP. So there's still a long way to go in our basic training, in our education, and things that can really make a difference for patient benefit. Slide 21. What about PEEP and recruitment maneuvers? Many factors in ARDS drive de-recruitment, alveolar collapse, and clinicians ask, can PEEP and recruitment maneuvers improve oxygenation and mortality? 3 large studies have addressed this, although not identically designed, sadly. Overall, none showed any mortality benefit from a higher PEEP strategy, but the EXPRESS trial suggested a higher PEEP did reduce ventilator-free days. Barotrauma was not affected by higher versus lower PEEP in these trials. So there is still a question about the use of higher versus lower PEEP, and maybe in patients with hyperinflammatory ARDS. Slide 22, please. What was clearer was that the use of recruitment maneuvers did not improve mortality in any of the 4 trials that studied this. Indeed, in the ART trial, the mortality was significantly worse in the recruitment maneuver group. This trial also showed more barotrauma in the recruitment maneuver group, and all trials showed more hypotension, and 2 trials showed cardiac arrests that could be possibly attributed to recruitment maneuvers. So the overall position is that prolonged high-pressure recruitment maneuvers are not supported by the evidence. Slide 23. Prone positioning can more evenly distribute lung stresses. It can improve right heart strain and has been the subject of several key ARDS trials. Back in 2013, the PROCEIVA trial showed prone ventilation was beneficial in moderate to severe ARDS. But other trials didn't confirm this definitively. A meta-analysis in 2017 did not show convincing mortality benefit. However, when proning was used for longer than 12 hours, always done with those with a severe PF ratio of less than 200 millimeters of mercury, then a benefit was shown. Slide 24. What is also important is the subgroups that have so far been excluded from the use of proning. And one of particular interest is those patients with brain injury. Although this study by Almala here recently done suggests you can consider proning if you can monitor both neurologic and hemodynamic parameters. Slide 25, please. What about awake proning? This is something we heard a lot about during COVID. There have been 3 trials in COVID patients. The stories suggested improved oxygenation by proning awake COVID patients. And these 3 trials did suggest that proning reduced the need for intubation. They didn't confirm any overall mortality benefit, however. Slide 26, please. Another field that needs to be looked at again in ARDS is the use of neuromuscular blocking agents. There was a good study by Laurent Papazan in France many years ago, which showed that 48 hours of infusion of neuromuscular blocking agents in moderately severe ARDS improved the mortality, presumably by reducing ventilator asynchrony. However, this needs to be looked at again because muscle paralysis can give problems and it needs deep sedation. And our approach to sedation and deep sedation has changed in ARDS over the last 2 decades. The recent ROSE trial did not confirm the benefit of neuromuscular blockade with no 90-day mortality benefit seen. Slide 27, please. Steroids are something that have come and gone and come back again many times in medicine. And this is a reference led by Chowdhury that has reviewed the breadth of recent evidence on steroid use in sepsis, ARDS, and severe community-acquired pneumonia. This consensus group, using well-defined methodology, made 4 recommendations. They support the use conditionally of steroids in septic shock and in ARDS. They strongly supported the use of steroids in severe community-acquired pneumonia. They did not support the use of short courses of high-dose steroids in septic shock. They could not make any recommendation on the use of particular steroid molecules or on the dose duration of steroid use. So the story still rolls on. Slide 28, please. Some centers can provide ECMO, which is extracorporeal membrane oxygenation. The technology for this has improved dramatically over the years, both the membrane oxygenation and the heparin bonding and anticoagulation of the tubing, along with the size and transportability of the equipment. And there are now quite well accepted criteria for the use of ECMO, and all of these need the ARDS to be severe, with a PF ratio of less than 50 millimeters for 3 hours, or less than 80 millimeters for 6 hours, or a significant acidosis with a raised CO2. Slide 29 looks at this further. There have been 2 large studies published, the CESAR trial and their early trials. And meta-analysis of these shows a significant reduction in 60-day mortality when compared with conventional ventilation for those with very severe ARDS using the criteria I described on the previous slide. Many reports suggest that this would be similar in COVID-19, but we don't have the definitive randomized control trial to confirm this yet. Slide 30, please. Others have used this technology to remove carbon dioxide and to see if this could help patients with severe CO2 retention. Here, typically, these would be patients with underlying COPD and lung damage. Neither the extravent or the rest trials have showed an impact on mortality. And of interest, those patients on ECOR, or extracorporeal CO2 removal, had fewer ventilated-free days by day 28. Slide 31, please. People ask, does COVID-associated ARDS differ from other forms of ARDS? There are well-described lab measurements such as higher platelets, lower prothrombin time, and APTT in COVID-19. There's a high instance of DVT in COVID-associated ARDS. Anti-inflammatory agents like steroids, IL-6 blockers, and one of the JK inhibitors are recommended in COVID-ARDS, but trials have not confirmed a benefit of these in non-COVID ARDS yet. So so far, both COVID and non-COVID ARDS seem to have similar 6-month cognitive function, which is important. Though more COVID-ARDS patients seem to return to work, but this is still open to further understanding and maybe another arena for subgroup analysis. Slide 32, please. So there's much to still understand in ARDS. And the next slide shows many of the avenues that are still being pursued. This slide is taken from the Lancet, published 18 months ago, and the reference it provided at the bottom. This is a good reference. As they note, potential treatable things in ARDS that could be identified by biomarkers are seen in italics, and these are aligned with associated pathophysiological mechanisms that could be targeted by novel therapeutic interventions. The pathophysiological model illustrated here probably does not account for the complexities of interactions between different mechanisms, and patient individual responses will also impact on this. Integration of multiple modalities of information, for example, clinical features, imaging, physiology, biological tests, and other data might delineate further subphenotypes that could reliably predict responsiveness to therapies and interventions. Thank you very much. Last slide, slide 34, please. So, thank you for listening, and my very best wishes to all of you in Ukraine. Thanks very much. Bye-bye.